It's my pleasure to introduce my colleague as well, which is Dr. Nora Osman, who will be kind of our lead for this kind of topic and then lead us into some fun discussion. I think the topic is a great one as it relates to medical students, and it's this idea of meaningful roles. Dr. Osman is here at the Brigham Women's Hospital and Harvard Medical School, where she's an associate professor of medicine. She runs the internal medicine clerkship, the core clerkship, obviously a big, meaningful piece of their year and so important to their growth, and has been very involved with the medical school here and nationally, thinking about this topic as we continually reform and evolve medical education at the undergraduate level, the medical student level. One of the core tenets here is trying to provide the most meaningful role within the competencies that these students have. And with that, it's going to be a fun discussion. So thank you, Nora, for doing this. And thank you all of us for joining it. And we'll stop sharing these announcements. I'll turn it over to you, Nora.
Great, thanks. Eric, you promoted me. I'm not associate professor yet, but I thank you for your confidence in me. Hi, everyone. It's nice to see you this morning. I'm going to share my screen. I'm especially excited to see some new faces and also some I don't like to say old faces, but some familiar faces, people who I look forward to engaging in this conversation with. So let's get started. I'm going to share my screen here. And I know people who know me at the Brigham know that I'm a little bit dreamy. So bring me back to earth if I get too dreamy, because we have some work to do today. The topic that Eric asked me to talk about is this idea of nurturing medical students to find meaningful roles or to work in meaningful roles. And I put those parentheses there because in my mind, I can't really separate meaningful roles from meaning, right? This idea that how do we nurture students actually to find meaning in the roles that they have? I don't have any disclosures. I just, part of my salary is paid for by a USAID grant. So before we started, I wanted to think a little bit together about this idea of meaning and meaningful roles. Shubha and Eric asked me to lead this discussion, but for me, it's this like constant struggle. What is meaning and what is meaningful roles? And it made me start to think a little bit about the hidden curriculum. So I wanted to talk very briefly with all of you about the hidden curriculum. Do people have an idea of what the hidden curriculum is, like how you think about the hidden curriculum? Anybody can just jump on and unmute and say what you think about the hidden curriculum. I don't want to call on people. So
I always think of it as the inverse of kind of what is kind of the upfront and obvious curriculum, what's written down, what's kind of labeled as expected pieces. And it's kind of what doesn't exist within that people can assume, or unintended assumptions are made. And people that hides underneath. That's the way I think.
Totally, exactly. So there is this idea of the formal curriculum, and then there's the informal curriculum, which is like what's not in writing, but it's sort of what we do, what we say, what we're explicit about. Role modeling, the stuff we do on rounds, at lunch, the stuff we talk about. And then there's this idea of the hidden curriculum, and these definitions come from Liz Gaufberg, who's a psychiatrist at Cambridge Health Alliance. And the hidden curriculum is these messages, right? These messages that are transmitted at the level of the institution, in our language, in our resource allocation. Remember, I'm a primary care doctor, so I think a lot about resource allocation as a hidden message, and also our policy. And in my mind, when I think about students and learners and meaningful roles, I do think about this struggle, the tug of war, sort of, between what we tell the students we want and then what we show them we want through team structure, right? Or clerkship structure. How much time is spent on the wards? How much time is spent in the ambulatory setting? And I want to put this to you right now. I know we're going to break into groups and talk together, but I'm going to put this little question to you right now. Can anybody think of an example of how this hidden curriculum might play into the idea of meaning and meaningful roles? Can anybody think of an example? I'm not looking at the chat. Should I be looking at the chat? Are people commenting in the chat? No. Okay. So here's my question. When you think about the hidden curriculum, can you think of an example of how this might play into this idea of meaning and meaningful roles? I have an example in my mind that I bounce around, but what do you guys think?
So Nora, this is Shubha. And one of the things we can say is, let's imagine the overt curriculum or the formal curriculum states that we're truly interested in teamwork, interprofessional interactions. And then our learners find out on rounds or in clinic that their clinical supervisor, and I'm making it generic to all health professions, they actually are speaking demeaningly of another profession. And so there's a direct conflict between the formal and hidden curriculum. This is not informal, but hidden curriculum.
I think it's such a great example. Yeah, absolutely. Anybody else? Thanks, Shubha. Anybody else want to give an example of that?
I think another example really, sorry. Another example that I think can be really devaluing, and whatever other antonym for meaningful you want to use, is sometimes students will hear things like, oh, well, it's too busy for you to do this, or I'm too busy to help with that. So it's like we say they're taking on a meaningful role to advance patient care, but then simultaneously signaling that if there's a time crunch, they're expendable and excluded from the process.
I think that's, such a good example too. Absolutely. Right. Like how
we say they're meaningful. Go ahead, Nora.
Go ahead, Eric. No, go ahead.
I think of it all the time when we tell students they should write their notes in the chart, and then no one reads their notes, essentially.
You bet. Right. And then how about this idea that I bounce around in my head of a good patient, right? Like, this is a good patient for you to take care of. This is not a good patient for you to take care of. Like, somehow the meaning of being a doctor or doctoring is dependent on the situation. It just feels like it's inconsistent with our professional development. Right. Great. So just a thought for us to sort of puzzle through a little bit. So I wanted to introduce some concepts for us. We're going to go into a small group in a couple of minutes, but I just wanted to introduce some concepts for us that we can use as we're working through the case. For us at the Brigham, we have this idea that we're working on, which is creating meaningful roles, because it's been important, because we're thinking a lot about redesigning our clerkships, as many of you on this call know. And we know we have a workforce of PAs and a work/learning force of students. And we're struggling a bit with the idea of how to make good use of and be mindful of the needs of both of those groups, right? While always keeping the patient and patient care central. How do the PAs form a part of the team? How do students do work that PAs don't necessarily need to do? All of these things we're sort of bouncing around in our minds. And we have some foundational ideas. Some, I said at the beginning, I'm a little dreamy. So some of these can be a bit more aspirational than others, but these are some of the ideas that guide us. And so the first idea is this idea on the screen. I don't know if any of you have read this article. It's from 2007, I think, or 2009. I can share the reference with you. And it's this concept of educational symbiosis. And this is the idea that medical students learn in and have to negotiate this series of bidirectional and mutually beneficial relationships. And this model puts students as the center node within these four axes, as you see on the screen, of relationships: the personal professional, the clinician patient, the university health or health service, the health service and the university for us, and in places where there isn't a health university, so that's different, but then government and community. And these relationships serve as the integral elements of the educational design, right? Relationships. And my point here, the reason I'm sharing this with you, is this idea that relationships can deeply influence professional orientation, skill building, learning, outcomes, maybe even more than the structures. So when we think about creating meaningful roles, can we actually separate meaningful roles from the relationships within our educational learning environment? So that's concept number one, is the symbiosis and relationships. And then the second concept that I wanted, or framework that I wanted to share with you, is this conceptual model that was introduced by a collaborative in the Alliance in Academic Internal Medicine, AIM. I call it AIM, but I think it's AAIM technically. And in 2017, they came together to create this model, a conceptual model to think about how to optimize the clinical learning and working environment. And this is sort of a holistic tool that describes the state of medical education today. It's kind of aspirational, but it can be used to design and create interventions. It's similar, for those of you who know, did any kind of public health. A lot of you will know Bronfenbrenner's social ecological model. And this is similar because it describes how multiple domains interface with each other and can affect and be affected by each other. But I'm going to tell you the key to this model. there are three main ideas, which again, I want us to think about as we go forward and think about how to create meaningful roles. The first is the central role of the patient. So medical education, let's remember, occurs in the context of patient care, right? And calling this context, let me say it, how do I say it? That we create this tension of service, patient care, versus learning, student-centered, right? And I think it creates this false dichotomy. And it's something for us to remember thinking about, because learning always happens within the context of patient care and meeting patients' needs, right? So it's not that we're there just to do service to our patients or to in a service-oriented role. We're also there as learning. It's happening at the same time. The second thing is the learning context that we're in necessarily has learners at multiple stages. So there are beginner learners, there are more advanced learners, there are peer teachers, we have senior residents with first-year med students, we have fellows with first-year med students. And because learners span this continuum, right? And there are other learners too. There are pharmacy students. I don't know how it is for other people in other contexts, but for us, a team can have a pharmacist, it can have a nurse, it can have, a clinical research coordinator. We can have all kinds of learners. And because of that, our learners can be both teachers and learners at the same time. So when we think about creating meaningful roles, that's an important thing for us to remember too. And then the third thing is this idea of the social cultural context. All of this is happening within a social cultural context, and meaning doesn't necessarily just have to happen within the specific clinical domain, because that clinical domain is part of a larger social cultural context where learners and doctors can have meaningful roles that are outside of the exact clinical learning environment. So the main point I really want people just to take from those two concepts is this idea that the learning environment and the working environment are intertwined and inseparable. And again, this sort of underscores that false dichotomy that I said before of education, meaning a focus only on the learner, versus service, meaning a focus only on the patient. All right, so two more things before we go to our small groups. I think a lot about how to support learners, and I see on the call there are people who are teachers, but also people who are very much in the student advising world, at least at the Brigham. And so I just wanted to think about a couple of things that will help us help us support our learners, because remember, a lot of what we do is, as teachers and mentors, we are shepherding young learners through a really, really new world for them, right? Like all of this is new for them. And so because of that, a lot of it can be scary and overwhelming. And I just wanted to very quickly refresh everybody on what the growth mindset is. So Professor Carol Dweck has this whole body of work on self theories, and self theories describe two mindsets. So when people hold a fixed mindset, they believe traits are immutable. They fear failure because it challenges their sense of identity, so they avoid challenge. And when people hold a growth mindset, they believe that traits can improve with practice. And so they have a mastery approach, which allows them to consider challenge and failure nutritive. And though we talk about people having one mindset or the other, this idea of having a mindset is actually a fixed way of thinking about mindsets, because people can hold a fixed mindset and a growth mindset about themselves and their surroundings, depending entirely on the context. So that's one idea I want us to think about as we're thinking about creating meaning and meaningful roles. How do we support our learners to go towards the things that may be uncomfortable for them? How do we support them to go towards things that are new? How do we support them to understand that they will fail if they challenge themselves? They will come up against things that are hard for them, and to recognize that those are actually nutritive, that they grow from that rather than falling down and never getting back up. And that brings us to this idea of the zones of comfort and discomfort. I don't know if people know about this, but there's this idea of the comfort zone. The comfort zone is the area where you're doing things you already know. You could dial it in. You could call. You could do this in your sleep. And if you're sort of stuck in the comfort zone, if we let our students live in the comfort zone and don't push them out of that, then they're never going to grow. The opposite is the panic zone, where they have very few skills. We throw them in. This is this idea of throwing them into the deep end. we throw them in. It causes such high emotion for them. They're so stressed out that they're overwhelmed and panicked and can't do anything. So how do we, with our learners, with our structures, our clerkship structures, with our institutions, how do we figure out where the sort of discomfort learning zone is, where there's some skills, students have some skills, students have some they don't quite have yet, but they have an idea about maybe what they are. How do we encourage our students in a meaningful way to them, to patient care, to the social cultural context? How do we work with them to figure out where the discomfort zone is, and then support them in that zone so that things from the discomfort zone can then become skills that they can apply in their comfort zone? All right. So as I said, I can be a bit dreamy. And I'm going to stop sharing for 2 seconds so we can think a little bit together about all that stuff that I just said, remembering that I spend, my head is in the clouds a lot of the time. So let's come back, think about what I just said, and then I'll put the case on the screen, and we'll go out into our rooms. What thoughts do people have about some of those concepts or ideas that I just brought up?
Nora, can I ask, for the purposes of this, how are you defining meaningful role?
Well, Nikki, let me ask you, how are you defining meaningful roles?
I think it depends on, I think it depends on if you're the teacher or the learner, right? I mean, and great. I think, and different stages of learning for students might have different ideas about what a meaningful role in patient care is. So that's sort of some of the challenges we have.
Right. So, but let's say because you're the teacher right now, you're the clerkship director. How do you think, and this is what our case will actually give us a chance to think about together in a group, but how do you think about what classifies a meaningful role? Like for you, Nikki Johnson, or for any of you on this call, what might a meaningful, if you were going to describe what a meaningful role was to somebody, what are some of the ideas or thoughts that you would have about that?
I would say any situation setting where the student can maximize their learning and professional growth. Okay. Which is very nebulous, but
it's not, right? So that brings us back to the idea that I brought up before, which is this idea for you, Nikki Johnson. The perspective that you're bringing is a very learner-centered one. You're saying that meaning comes. A meaningful role means that the student gets something out of it, that it's an opportunity for the student to learn. And that's what I was bringing up before, this idea of a bad patient, right? Or like not a good patient. Is it impossible for a student to have a meaningful role in caring for a patient? I'll give you an example. In medicine, we often will say, like, this patient just has failure to thrive. He's just going to sit here for 2 days waiting for placement. That's not a good patient for you. But it's a good patient for the doctors on the team to take care of, right? We have to take care of that patient. So is there no meaningful role for the student there? I don't know. Becky.
Well, the reason why when I was thinking about this the other day, we were trying to define it for ourselves. And in a surgical field, if you flip it and say it's any role that then benefits the patient, the problem in a surgical specialty is that, you could argue from a student's perspective, being able to suture, right, let's say, or deliver the baby, to them would be incredibly meaningful. But to the patient, that's not necessarily the case, because that suturing could take 3 times longer than it should be normally. And then patients under anesthesia for 3 times longer, right? So you get into the weeds of what truly benefits the patients. I think in a non-surgical setting, you could argue, any longitudinal relationship and advocating for the patient and doing, could certainly benefit the patient. But when you start talking about procedures and other things where students are sort of learning, exam under anesthesia is another one. There's no benefit to the patient whatsoever, but there is for student learning. So it gets a little muddy, I think, when you flip it and say the patient's at the center of that. In my mind, anyways, I'd like to keep the learner at the center.
Mm-hmm. Right. So that's the dichotomy that I was talking about, this idea of focus on the learner versus a focus on the patient. Becky, you were going to say something?
It's interesting. as a non-procedure person, that it was really interesting to hear that perspective, Nikki. I was thinking about, this gets to like how we define meaning, which I guess is the point of the discussion, but the failure to thrive patient, as you say, I think that's a case or an example where the authentic relationship and the actual looking for what the meaning is an area where we undermine what the meaning could be by saying it's not a good case for the student. And the students actually sometimes could teach us. I think there are a lot of times when the student's relationship with a patient that might be considered like boring or straightforward or whatever, can actually tell us more about where we're not doing a good job of care and where we could do better. But how we position that as part of the curriculum and an important part of the curriculum relative to these like hard skills that they need to get, I think is part of the challenge and part of that hidden messaging where they kind of get the message that they do need to learn suturing, but that they have to learn it in this particular block at this particular moment, kind of devalues some of the other things that they need to be learning all the way through.
Yeah, it really, really interesting. Yeah. What are we telling the students and what are we showing the students, right? We would never write in the curricular guide, these patients are terrible for you to learn from, right? We would never say, these are what we consider bad patients. We wouldn't say that. And yet somehow we do model that to them. Oh, don't worry about this one. Or I loved what Ariel said, or somebody said before about like, we don't, Eric, I think it was you, we please write a note, but then we don't read it, right? Like that, what is that signaling to our students? Yeah. Okay. So we have a small group we're going to break into, right, Eric? Is that what you're going to say?
Francesco had one comment.
Yeah.
Okay. I was just going to say, when you're thinking about this dichotomy between the patient and the doctor or the medical student, I think conceptually, if we expand that a bit, we can solve some of that problem, because as a patient, I want the student to learn. I'm probably going to be a repeat patient. I remember stabbing my hand as a teenager and being asked if the 5th year medical student, we have a 6-year system in New Zealand, could suture my hand. Now, there's no immediate advantage to me in that, except that I'd like that student to be able to suture, because, you know, I was a bit of a stupid teenager and I was probably going to be coming back. So, you know, that's it. I know that that's a conceptual game or trick, but I think it's actually valuable to remember that for all of the patients, to some extent, you're going to be a repeat patient. And which patient are we talking about? Is it the patient on the table or the next patient on the table?
Right. Right. Gaston, quick, you're the last one, and then we're going to go to small groups and come back. You don't have to be quick.
Okay, yeah. No. I'll be quick. Actually, I have to leave at 11:30. But one thing that I really like, I never thought about this in the context of medical education, is the comfort zones that you showed, which reminds me a lot in psychiatry, mental health, about the optimal level of stress, where people actually are more able to assimilate verbal information. And we don't think about that too much in teaching, but I'm actually thinking from the teacher's perspective, creating because it's going to be different from learner to learner, what their comfort zone is, and creating the environment where they are in that range where they can learn. I think that can be, for me as a teacher, much more meaningful to be in that role where I'm actually, trying to detect, am I pushing too much or am I actually keeping them too comfortable? So anyway, just wanted to say that.
Yeah, great. Good. Thank you.
Nora, can you put up the question again and everyone can just read it? And then I think Caitlin will put us into 4 groups and we'll have groups of about 4 or 5 in each, which will be fun.
Can everybody see that?
Read it? Go ahead, Nora, you can read it.
Yeah, so you're an attending on a busy inpatient medical team, and your team consists of a day resident, a night resident, 2 interns, a senior student, Sam, and a junior student, Taylor. Hi, Taylor. I didn't know you were going to be here today. The census is very high, and you've been given license to organize the team however you wish for a 2-week pilot. So imagine COVID, census is through the roof. You can do whatever you want with these teams. You can put the students and the residents on the days, on nights, together, not together. You can do whatever you want. So some of us are going to think about what are some of the strategies you can use to create and support meaningful roles for learners. Just think big, whatever you want. And then the other group, you guys are going to be the problem solvers here. How do we identify and overcome some of the barriers? Because we all know there are going to be barriers to this. So how do we overcome some of these barriers that we know will exist to creating meaningful roles? Questions about that, your homework, the group assignment?
We're going to have groups 1 and 2 take that first question, and take 3
Create
and 4
roles.
take the barriers.
And we'll take 15 minutes and then come back.
Super.
With the
Yep.
group reports. Yeah. Okay. All right. So everyone's coming back, and we will let Nora, each group go and debrief.
Or did we not?
Well, I was going to say group 1 had no clinicians. So we were talking about like the comfort zone, the challenging zone, and the panic zone. If we were truly in charge of these decisions, we would be beyond the panic zone. We would be far out from a positive learning environment there.
The off the chart zone. Yeah.
I think what the little tiny thing we could potentially add to the conversation, because we try to talk about something, was that even in the moments of like high stressors and when everyone is at their max capacity, perhaps it would be important to try and define these roles that we're giving to these students. And, there's going to be a spectrum, from a 4th year to a 1st year, what they're capable to do in these different levels of zones, but maybe helping to define for those students the meaning and the impact that they will have based on what role that they're taking on in that moment. So that way, if they aren't able to initially see what the impact is or how their role is meaningfully kind of intertwined into this larger ecosystem, maybe some guidance or just some explanation of that to the student will help them feel that what they're doing is more meaningful than perhaps if they didn't get that in the first place.
Right. So you're talking about being explicit. And I think that's absolutely right. Right. Like to the extent that we can articulate it, we should articulate it. You bet.
Yep.
Yeah.
Mm-hmm. We did have a clinician, Fiona, join us.
Oh.
And so that was really helpful. She was talking about the situation in the UK and what they do with their folks. And that was really helpful. It gave us some insight. Yet, like, you don't want to have too many students during a pandemic, and everyone has to be clear on their roles. And debriefing at the end was really, I thought, crucial. That was a really good point.
I love that. The idea of debriefing afterwards, right? We try to do such a good job of talking about things beforehand, whether we succeed or not, I don't know. We try to, but we're even though, theoretically we're supposed to be looking back and saying what worked, what didn't work, how did people process what just happened? I think we could do a much better job of that. And to Alex's point, that would help us define it, right? Like it's a living, breathing document, sort of this definition of what it is to have meaning and have a meaningful role. Good. Thanks. Group 2.
Group 2, anyone can weigh in, but I'm happy to start. I won't capture everything, but I think we did have this interesting reflection that when we were talking about ideas to create meaningful roles, there are these processes which appear more structural or curricular, like you put a student somewhere because that defines them in a role and whatnot. But then there's also, if you will, the processes of teaching, and that can also empower meaning. And there were many examples of it. So like on the former, the kind of structural piece, Francesco was saying the idea of pairing up with a doctor. Your job is to watch the doctor, but naturally by creating a small team like that, you almost empower them to be more meaningful and be helpful. They're not just kind of watching, they end up kind of learning. So that's kind of a structural way that it occurred. And then on the other side, the process, we talked, some of us are using the process of kind of so-called going up the ladder, that if you have a team of many learners, you always start with the lowest and you say to them, we have a lumbar puncture to do. Would you like to be a part of that supervised? And they decide themselves if they are in that zone of comfort or risk, or whether they don't want to. And if they don't want it, you go up to the intern and you go up from there. So those were some of the thoughts. Anyone else in my group have anything that I surely missed? All right,
great.
There you go.
Group 3, thank you. Group 3.
So group 3, so I'll go first. And essentially, we were supposed to think about barriers. And so the barriers here are sick patients, the high census on the service, and the competence and skills of the students being uncertain about their competence and skill level contributing to patient care. And for the teachers, the big challenge is how to address multiple levels of learners, and particularly how to get the junior learners. So some strategies, or the supervisors in this situation have so much freedom and flexibility to ensure that students have a meaningful role. For example, as a clinician, as a future clinician. And so make sure that they are engaged with patients, building relationship with patients, interact with patients, examine patients, and learn through that, and then have this sense of competence, growing competence. Then the other thing we thought about was make sure that the students have a sense of belonging as a team member. They are part of the team, they have contributions to make. So those are the main things we discussed.
Mm-hmm. Right. And we're seeing this theme throughout, right? Like be clear about expectations. And also this idea that you just said at the end, which is make sure that the students feel like they're part of the team, right? And I think Eric's point before reinforces that too, where you actually ask the student, what is your comfort level, right? What's your comfort level with this? Means, I think you're important. I want to hear how you feel about this. And it's, I think it's part of the same idea that you're talking about here, Shubha. You are part of the team. You're part of the team. Good. Thank you. Anybody want to add anything to group 3? All right, group 4.
I offered to report out. We had Christina with us, so of course we knew we needed to designate a reporter. But I think we talked about a few things in terms of identifying barriers. 3 things we identified were just the time constraint. The prompt you gave us had this idea that it's particularly busy service time. The second was sort of what I would group together as like how we're defining our terminology and how that intimately relates to culture. And I think that was the discussion we were having before about like, what is a meaningful role, and like the false dichotomy between education and service, and sort of trying to create a culture where we see that like that overlap is actually massive. And there's a lot of opportunities for learning that intimately advance service, and sort of, especially that interplaying with the time constraints and not allowing us to slip into this habit of like doing that. And we also were talking a little bit how that totally helped in my mind clarify like why you started with the hidden curriculum as the prompt, because we have some pillars of learning that our hidden curriculum constantly devalues that are in that overlap, like systems-based practice being the one that I was perceptively using as an example, as like things that we devalue, but are absolutely in a space of that overlap between service and education that, especially if you also have a time constraint, are important to prioritize. And then I think the third barrier we were talking about has been the most common theme across groups, which is like, make sure we're collecting data. We were talking about that specifically in terms of the learning environment, and just making sure we're actually having an open discussion about what is the impact of the time constraints. Are we actually doing meaningful learning, instead of just like that being sort of a background thing, like having that. And I think that's like what a lot of other groups were bringing up in different ways. I just, because I'm a very quantitative person, use the label data.
Thank you. Good. That's great. Thank you. So it sounds like some common themes here. And this idea that I brought up in the beginning of, is it meaning or is it meaningful? And are they the same thing, right? Can you have a meaningful role without the student and the learning environment considering that to have meaning too, right? And can you separate those two things? I think we talked about here. The other thing is there is meaning in struggle, right? There's meaning in going towards things that are hard. There's meaning in work. And I think as educators, for us to find, to help the students see that, is important. I think there's a lot of value placed on the grade, right? Grades are really meaningful. Assessments feel really meaningful to our community of learners. But what about the struggle too? I think that's really important. If there's time, I want to share one other quick idea with you, and then I'll give it to Shubha. Or Shubha, are we done? And we can talk some more another time. You tell me. It's super quick.
Yeah, go ahead.
So I want to introduce this idea of students actually being part of the source of the meaning, of being part of the community that defines meaning. And I want to give you the example. I had a slide, but I'm just going to tell you an example of meaning and assessment. At UCSF, they found, and I can share the reference with the BEI team, and I'll give this to you. They found that students, particularly students from historically underrepresented groups in medicine, found that they were not being assessed on things. They were not being assessed on things that they thought brought meaning, specifically patient advocacy. They were not being assessed on patient advocacy. So they were spending a lot of time advocating for their patients, and they weren't being assessed on this. And that felt like a real conflict for them. And so the faculty and the students partnered to create an entirely new assessment domain. And this assessment was student advocacy, and it was patient advocacy. And they had this domain, and they had metrics, just like they have metrics in medical knowledge and clinical reasoning. They had metrics, and they now use that as part of the way they assess their students. So this partnership, I thought, was such a beautiful idea, a beautiful example of how to create meaning, partnering with the learners and having the patient be central to that. Just another way of thinking about this.
Thank you very much, Nora, and thanks to everyone who participated. It gives me pleasure to bring this to a close, but then I'm going to take a lateral step. And I want to go beyond medical education and apply this to all professionals. And so here's a couple of things. So what are teacher and educator roles in terms of promoting or fostering meaningful roles for their learners? So I would like to go back to the self-determination theory, which is all about intrinsic motivation. I think from a 20,000-foot view, I'm not going into the weeds, I think teachers need to instill or nurture intrinsic motivation. And so there are three psychological needs of learners that we must meet. Competence. So ensure that they're able to gain knowledge and skills and increase their competence. Autonomy, not just let them fly on day one, but really appropriately and progressive autonomy. And then relatedness. I think we basically talked about relatedness, feeling the sense of belonging to a group or community. And as teachers in any healthcare profession, it's worth remembering this. And I just wanted to end with this model, which was described by Tim Dornan, one of the world's great educators. He currently at Belfast, I think emeritus almost. And he talked about experience-based learning. So essentially, the learners need to be self-directed in many ways. So what do they need to do? They start as a learner and they go through, in the clinical realm, they go through patient care, their patients, they are the learners, and they interact with their junior doctors, their near peers, and their teachers. So that's the circle in the middle. They learn, that's pedagogy. But then real patient learning is what is so meaningful. And then there are three things that then happen. They gain knowledge and practical skills, the intellectual, practical, but most importantly, the affective or attitudinal skills. So what do teachers have to do? Support, establish safe learning environment, facilitate transformative and not informative learning, I think, which is what we've been very good at in the past. So take a step back and nurture a growth mindset, meaning mistakes will happen. All of us have strengths. All of us have areas to improve. That's the way it is. So people can acknowledge their limitations. And then role model. And role modeling is not part of the hidden curriculum. We can explicitly role model by debriefing the so-called soft skills, which I think are the hardest skills of all. Facilitate entry into the community and foster that self of belonging. And finally, foster professional identity. I am a nurse. I am a therapist. I am a doctor. So that's basically all I had. This World Cafe, as you know, is a rather innovative style of a session, and we are very, very interested in your feedback on these sessions. So Yi will email all the participants. Please do provide your feedback, very short, I think 2-minute survey, and we're really interested in continuing to improve. With that, I would like to bring this session to a close. Thank Nora for doing an amazing session.
Thanks.
It was so fun. Thanks for everyone. And good morning, good night, wherever you are in the world.